Let's look at some now examples of dyslipidemias, diseases where there is imbalance of lipids or imbalance of lipoproteins. Okay? As we have seen now, there are many types of lipoproteins, so there needs to be a balance in the body. If there is imbalance, it can lead to dyslipidemias. The hyperlipidemias can be divided into two major categories, primary and secondary. Primary is where it is due to some primary defect in the lipoprotein metabolism. Secondary is due to another disease process. For example, chronic renal failure, hypothyroidism, where there is some effect on lipid metabolism and it presents as hyperlipidemia. Now, this is a classification of dyslipidemias proposed by Fredrickson. Okay, it's a very interesting classification. So you take the blood sample from the patient and you let it settle for few hours, and when you look at the sample later, if you see something like this, you have this blood settling down, you have this very creamy whitish substance on top. These are chylomicrons. Okay? If you have a generally milky kind of solution, homogeneous milky, this is VLDL in high amounts. So looking visually at the sample, you can see this kind of pattern. Okay, so which is used to classify these dyslipidemias, and it's a very complex classification system, not used nowadays. Let's look at some common dyslipidemias. Hypercholesterolemia, so cholesterol is high. Cholesterol is present mainly in LDL, VLDL and IDL. Okay. This is most common form of dyslipidemia. There is one category which is called familial hypercholesterolemia, so it is a genetic condition. Hypercholesterolemia has a very strong association with atherosclerosis, heart disease, so on and so forth. Okay. Hypertriglyceridemia, when you have increased triglycerides and increased VLDL. VLDL is the main particle that contains large amounts of triglycerides. Okay. Associated with fatty liver disease and diabetes mellitus. The effect of increased triglycerides and VLDL on cardiovascular disease is not well established. So those people who have high triglycerides and VLDL, most commonly they have either a fatty liver disease or they are in those people who are prone to develop diabetes. Combined hyperlipoproteinemia, where you have both total cholesterol and triglycerides increased in a patient's blood. Again, you have increased risk of coronary heart disease. But what is the difference between those people who have combined hyperlipoproteinemia and those who only have hypercholesterolemia is still not clear. Okay? Because as I told you, having only triglycerides increase in the blood doesn't increase the risk of atherosclerosis and the heart disease. But cholesterol increase does. Okay. Lipoprotein A elevation is not very common, but in those people where it is elevated, it is also associated with increased risk of coronary heart disease and cerebrovascular disease, stroke. Okay. Sometimes you can have hypolipoproteinemia. Most commonly, it is hypo-alpha lipoproteinemia. Don't mix this with the apoproteins, alpha and beta. This is not alpha apolipoprotein. Okay? The clinical significance is not very clear, but hypo-alpha lipoproteinemia is where you have isolated decrease in the circulating HDL. And if you remember, HDL is the good guy. When you have decrease of HDL more than the decrease in others, then you have increased risk of premature coronary heart disease and cerebrovascular disease. Make sense? Okay, lipid tests now. Commonly, there are few lipid tests which are done in the lab. Before we look at those tests, some common lipid and lipoprotein population distributions. Women on average have higher HDL cholesterol, okay, but lower total cholesterol and triglycerides level than men. Because of this, women have less risk of coronary heart disease. The incidence is much less than men. But after menopause, this difference is no longer there, the total cholesterol difference, because this is due to the female hormones, estrogen and progesterone, mainly estrogen. So after menopause, when estrogen is no longer there, this difference also disappears. So after menopause, the incidence of heart disease between men and women becomes kind of equal. Okay? Total and LDL cholesterol and triglycerides all increase with age, both in men and women. So there is always a steady increase both in men and women. Total cholesterol, LDL cholesterol and triglycerides are much lower in young children, than in adults. At puberty, the boys' HDL cholesterol drops 20% to adult male levels, but girls' HDL levels do not change. It's not completely known what is the reason, but probably it is to do with hormones. Yeah. The lower rates of LDL cholesterol and heart disease is found in Asians generally. Okay? So this is general population distribution of different types of lipoproteins. Now looking at the lipid tests which are usually done when you take blood sample, you measure total cholesterol. Now when you're measuring total cholesterol, you're measuring cholesterol across all the lipoproteins, right? You're measuring it in whatever is present in VLDL, LDL, HDL, right? And all the particles which are there. But in addition to that, we also would like to measure the cholesterol which is only present in HDL or cholesterol which is associated only with LDL. Because as you know, total cholesterol may not give us the whole picture. We want to know which particle is having more cholesterol than the other to understand the complex relationship of these particles. And also we'll measure the triglycerides present, the total triglycerides. Okay? Sampling, usually we take fasting blood sample to measure the lipid, all these lipid tests. The reason, because after having a meal, everything will change, right? Because you will absorb a lot of triglycerides, chylomicron will release, and everything will be different. So you take fasting sample. No alcohol consumption in the previous 24 hours. Alcohol can affect the liver metabolism of lipoproteins. So alcohol should not be consumed 24 hours before the test is taken. Serum sample is preferred. Minimum venous stasis. So when you're taking the sample, applying the tourniquet, you should not apply it for a long time. So minimum venous stasis. Normal diet and exercise for the preceding 2 weeks. This is the ideal. If it's not possible, then of course you can't do it. But if you can, this is the ideal situation where you would like to take the sample from the patient. If you look at the values now, so it's given in milligram per deciliter, but also in millimoles per liter. Total cholesterol, HDL cholesterol, LDL cholesterol, and triglycerides. These 4 things are usually measured. This is the unit conversion. If you get the values in millimole per liter for cholesterol, whether it is total, HDL associated, LDL associated, you can use this formula. For triglycerides, this is the formula. Okay, so you can interconvert the values. Now, lipid tests very interesting thing about lipid tests that they have a lot of limitations. All right. So all current test methods share a primary limitation, which is lack of accuracy. Also, there is lack of precision or imprecision. The current accepted limit of imprecision is the coefficient of variation of 5%. If it is more than this, then you will not accept the results. Ideal is less than 3. Okay. Now, what this means, I will explain this to you later about the gold standard techniques and the commonly used techniques that are offered by the labs. Also, there is bias. The current accepted level of bias is less than 5%. So, when you're talking about quality assurance in the lab, lipid tests is a very important aspect of that, because you need to make sure that the variation in results are within the acceptable range. Okay. Now, atherosclerosis, we already discussed the single leading cause of death and disability, and this is from the coronary heart disease risk factors determined by NCEP, National Cholesterol Education Program, I think, NCEP. They have come up with these guidelines, and you can see all the positive risk factors. LDL cholesterol, if it is more than 160, if it is more than 130, if it is more than 100, so different combinations. You have to look at the patient's family history, other factors, and the lipid levels, and then you classify the patient, how much risk the patient has of developing coronary heart disease. Now, these are the negative risk factors. If somebody has high HDL cholesterol, you see, more than 60 or more than 1.6, this is good news. If somebody has less than 100 milligram or 2.6 millimoles of LDL cholesterol, this is good news. All right? Make sense? Yeah. Also, in addition to this, they have come up now with dietary guidelines in those people who are at high risk of developing coronary heart disease. These are the dietary guidelines. TLC is therapeutic lifestyle change. Okay, therapeutic lifestyle change. This is the diet. So the total fat in your diet should be between 25 to 35%, out of which less than 7% should be saturated. But right now, in an average American diet, they are consuming 15% saturated fat, okay, every day. So the goal is to bring it down to less than 7%, monounsaturated less than 20%, polyunsaturated less than 10%, carbohydrate this much, fiber this much grams per day, proteins around this much. So this is the recommended diet for those people who are at high risk of developing coronary heart disease. Hyperlipoproteinemia. So these diseases are associated with elevated lipoprotein levels. You can have hypercholesterolemia, hypertriglyceridemia, or combined, as I told you earlier. Hypercholesterolemia is the most important one. Okay, most closely linked to the heart disease. There is this familial hypercholesterolemia, which is a genetic abnormality. If the patient is homozygous, which is quite rare, these patients will get their first heart attack in teens. Heterozygous is more common, 1 in 500. So it's quite common actually. So these people, heterozygous, you know, homozygous, heterozygous, the two gene copies, right? So heterozygous for familial hypercholesterolemia, they also have a high risk of coronary heart disease. Okay. Hypertriglyceridemia, as we saw earlier, elevated triglyceride levels could be due to genetic or hormonal abnormalities. This is not directly linked with heart disease, hypertriglyceridemia. Combined hyperlipoproteinemia, which is both cholesterol and triglyceride, increased risk of coronary heart disease. It also has genetic forms. Lipoprotein A elevation could be present in some patients, and there is increased risk of coronary heart disease. This test is not done routinely, but in special cases you may have to order this. Hypolipoproteinemia now, low levels of lipoproteins, hypo-alpha lipoproteinemia and the beta, as I told you earlier. The alpha lipoproteinemia, if there is isolated decrease in HDL. So the others are not, LDL is not decreased, but HDL is decreased. This will increase the risk of coronary heart disease. Now, sometimes what we can do, we can measure non-HDL cholesterol. So measure cholesterol in the HDL and measure the whole cholesterol which is not in the HDL. There are many studies, but this is a disease which is affecting a lot of people. So there has been a lot of research on this about trans fat, unsaturated fat, polyunsaturated fat. But if you remember what I told you in the beginning, most of the cholesterol is actually formed in the liver. You're not taking it from your diet. But these different types of fats, polyunsaturated, unsaturated, or trans fat, they can modify certain enzymes in this pathway, or they can modify the liver's function of making cholesterol. So fish oils are the best. Omega, you may have heard of this omega fish oil. You have these capsules nowadays, so all those things. Then plant source polyunsaturated or unsaturated fatty acids are better than the red meat or the butter that you get from the milk. So a lot of research on this. Okay. Now, if you look at the non-HDL cholesterol, if non-HDL cholesterol is increased, okay, of course, it will be associated with increased risk of cerebrovascular disease, because the cholesterol which is in the HDL is going back to the liver, but whichever is not in HDL is actually spilling out into the tissues and causing all these problems. Make sense? Okay. And based on these tests, there are decision cut points. As I was showing you that table, different levels of LDL, cholesterol, you classify the patient's risk stratification basically. So there are guidelines which can be used. Cholesterol is measured using this technique where you extract the cholesterol after hydrolysis, and then you put this coloring reagent and you see the color. This is the technique which is used routinely in the labs, but the reference method is this one, gas chromatography mass spectrometry. Not available in all the labs, but this is the reference method. So if you are using any other method, it has to be compared to this method. So if you are doing this quality check, for example, so you do run the same sample through GCMS and the other technique you're using, and you compare the results. If the other technique gives you results very close to the standard method, then you can accept the results. Triglyceride measurement, again, the reference method is GCMS. Whenever you run a test, you have to standardize it against the gold standard method. This is the commonly used method where you put certain enzymes and then you will see this color which can be measured by different kits. For lipoproteins, it is the sample is ultracentrifuged, then you do electrophoretic separation, then you do chemical precipitation, then you can look at different colors, or you can do immunochemical techniques to identify. Okay. For HDL, there is a 3-step process. First of all, you ultracentrifuge the, when I say ultracentrifuge, the ultracentrifuge means very high speed centrifuge. Okay. So what will happen, that VLDL is bigger than HDL, the size difference, right? The density difference. So you can separate them by using ultracentrifuge. Then you will do this precipitation to remove LDL from the sample, and then the remaining sample you will do this particular assay to identify HDL cholesterol. Okay. LDL is ultracentrifugation followed by chemical precipitation. It's easier than HDL. There are some other methods which are used in routine labs. Now we have these point of care equipment or compact analyzers. So you can actually take a finger stick, a single drop of blood, and you can measure cholesterol, triglycerides, HDL cholesterol, glucose from the same sample. Okay. Now these compact analyzers are not very precise, but with advancement in technology, they are now getting closer and closer to the gold standard methods, so the results are acceptable. Okay. Apolipoproteins, in some cases you may have to measure the apolipoproteins. Rare diseases where there is deficiency of a particular apolipoprotein, different techniques are used, mainly immunoassays. Okay. If you remember, ApoA1 is the main apoprotein in HDL, right? ApoB is main in VLDL and IDL. Phospholipids can also be measured by enzyme reaction sequences, but you don't need to memorize these. Fatty acids can also be measured by different techniques. So if you see the difference from other lab tests that we have discussed, this one is much more complicated because these are lipids. So you need very precise methods to identify them separately. Okay, this is the take-home message. Precision. Changes in diet, exercise, weight, smoking, other clinical conditions like diabetes, hypertension, diseases, medications, conditions in blood testing can all alter measurements. When I say conditions in blood testing, it is patient is standing or lying down. It can also make a difference. Then how long you apply the tourniquet, venous stasis can make a difference. All these factors can make a difference. So that's why when you're collecting the sample for lipid measurement, try to minimize as many of these factors as possible. Okay. Accuracy. So as I told you earlier, any lab which is doing lipid tests should be able to demonstrate that their results are similar to the gold standard method. So time and again you do this quality check to make sure that your technique is giving the results which are close to the gold standard technique. Okay. Matrix interactions, because these are lipids, you know, these lipids can have a lot of interactions with other components present in the sample. Okay, so there are now certification programs to ensure accuracy and to minimize matrix interactions as well. Now, what are the standardization goals that have been identified by this NCEP? All right, so they say that for total cholesterol, performance goal for total error is 8.9%. So within this range, the error is acceptable. If it is beyond this range, then it is unacceptable. Commercial control materials may not approximate patients' specimens. Now, sometimes you have these standardized samples that you can buy. So this sample has a particular concentration of cholesterol, for example. You run that sample in the machine, then you run the patient sample to compare. But now what is happening, the commercial control materials are not recommended to be used. Actually, you prepare the control materials from the patient's serum. Okay? So from the patient's serum, you somehow extract these lipids, cholesterol, you prepare standardized samples from that, and then you compare it with the patient sample. You know what I mean? Okay? So from patient sample, you take cholesterol, for example, or triglycerides, and you prepare standards, different concentrations standards. You run them through the machine, then you run patient sample. Okay, so this is the way you can standardize them. All right, specimen collection again. So if you take specimen while standing, then reclining, you could have higher lipid levels. So the standard technique is you ask the patient to lie down at least for few minutes before you take the sample. All right. Venous stasis should be avoided as much as possible. There is difference between the venous blood and the capillary blood, because when you're using these point of care or these portable machines, you take capillary sample, but when you're taking blood sample for the lab, you will be taking the venous sample, right? EDTA, which is the primary anticoagulant used, if it is present, then you have to use this correction factor, because it can affect the lab results. So there are so many confounding factors when you're looking at lipid results. So you have to take care of all these factors. All right. Now this is the acceptable, the range, or they call it performance goals. For total cholesterol, 8.9% error. Okay. For HDL cholesterol, it's about 12.8%. For LDL cholesterol and for triglycerides, again, see, it's 11.8 or 14.8%. So this much error can occur using different techniques, patient factors, sample collection, and the material and the technique that you're using. So if this much variation is there, it is still regarded as acceptable. Okay, that's all. So these are some of the questions that you can review. Okay, important points. Any questions? It's a bit complicated. The take-home message, I think, is very simple. You have to look at HDL cholesterol, total cholesterol, and LDL cholesterol. Now, previously, few years ago, it was HDL-LDL ratio. So the ratio was very important. Now ratio is outdated. Now we look at HDL cholesterol value as such, okay, and the total cholesterol, and of course other factors present in the patient. Okay, and remember these quality assurance challenges with the lipid tests. Okay, thank you very much.